Hi, everyone. Good afternoon. I'm going to give it a minute, let everybody get in. Lane, if you want to let me know when it looks like everybody's in.
So
We currently have 79 online.
What's that? So close the door.
All right, let's get started. If everybody would make sure they're on mute. Good afternoon, and thank you for being here. I'm Amy Fouts. I'm the chair of the Health Law section and a partner at Baker Hostetler here in Atlanta. I'd like to welcome you all to the first and hopefully the only virtual advanced health law seminar. I know everyone, particularly myself, is disappointed that we're not able to gather this year at the Four Seasons. I think it's the one time of the year that many of us who work together actually get to see each other in person. In fact, in thinking back and preparing for this, I think this is the first time that I haven't been to the seminar in person for the last 15 years, and I know that's the same for many of you. We are all looking forward to when we're able to get back together in person, but the executive committee is working now on ways that we can connect, since it looks like we are going to be dealing with this pandemic for the foreseeable future. In the meantime, we have a great program for you today. Next Wednesday, Rebecca Merrill and Wade Miller will lead us in covering healthcare transactions in the hospital, physician, and post-acute care setting. We will also have a segment on professionalism, inclusion, and diversity. So you will receive a professionalism hour for attending next week. And finally, on Wednesday, the 28th, we will have our fraud and abuse panel, which will be led by Bob Brennan and Aaron Danzig. We will cover updates on the CARES Act funding, followed by the current and anticipated enforcement actions that are likely to come from the distribution of these billions of dollars. This session will include 1 hour of ethics credit. A few housekeeping items. Everyone, you should be on mute and your camera turned off so we can minimize the distractions for our speakers. Your chat function is on. If you have any issues or problems with anything, please reach out to our moderator, Lane Sosby. Also, if you have any questions, if you want to submit those through chat, if we have any time at the end of the session, we will get to those questions. The materials that we have today, those will be sent to you in an email that you use to register after the session today. If you have any questions or issues on that, please feel free to reach out to me or Lane. Before we start today, I'd like to thank Mary Jo Sullivan and Lane Sosby from the bar for their help in putting this together. They've been very patient and supportive, so thank you. I would also like to thank the executive committee for their hard work and efforts and support in putting this together. And lastly, a big thank you to our speakers. I know everybody is consumed with what's going on today, and we have a lot of extra burdens. Most of the topics that we're going to cover during these series are changing on a day-to-day basis, and we're inundated with new information, new guidance, and questions. And our panelists have been diligently keeping up with this and updating their presentations. So thank you, thank you, thank you for your time and your effort. It is appreciated. We're going to start today. Our first session is a fireside chat with Kerry Connolly and Professor Aaron Fusay-Brown regarding price transparency. Kerry Connolly is also presiding over the seminar with me today. She has been instrumental in putting this together, so thank you, Kerry. For those of you who don't know Kerry, she is the General Counsel and Senior Vice President of Healthcare Policy for the Georgia Hospital Association. During her almost decade with GHA, Kerry has worked to promote the health and welfare of the public through her work with the association's members. Kerry currently serves as the Secretary of the Executive Committee of the Health Law section. Her insight and dedication have been invaluable to our committee and this section, and also providers across Georgia, so thank you for that. Kerry previously practiced with Nelson Mullins Riley in Scarborough, and she received her law degree from the University of Georgia. We also have Professor Erin Fusay-Brown, who is an Associate Professor of Law at Georgia State University College of Law, where she is the Director of the Center for Law, Health, and Society. Erin's areas of expertise, which are many, include health law and policy, healthcare financing, the regulation of healthcare markets and competition, the Affordable Care Act, the single payer and public option health reforms, consumer financial protections for patients, healthcare consolidation and prices, and surprise medical billing. Her work has influenced health policy at the state and national levels. She has presented her work to the Federal Trade Commission and has consulted with the National Academy for State Health Policy, the Milbank Memorial Fund, and the Georgia Health Policy Center. Before going into teaching, Erin practiced at Ropes and Gray and clerked for the District Court Judge Alan Kay in the District of Hawaii. She received her law degree from Georgetown University Law Center and an MPH from the Johns Hopkins Bloomberg School of Public Health. Thank you both for being here today. And with that, I will turn it over to Kerry and Erin.
Thank you,
Thanks,
Amy, for that nice introduction. I'm excited to be here today with Professor Brown, who really is one of our national experts on healthcare price transparency through her work at Georgia State. We're lucky to have her here locally. It's my belief that if we weren't in the middle of a worldwide pandemic, that this would be one of the main topics in healthcare policy that we would be talking about right now and probably for the most part of 2020. So, Professor Brown, before we really get into the meat of the topic, let's get a little bit of a sense for what price transparency is. We hear that term a lot, but I think it means different things to different people. What does it mean to you?
So price transparency is really designed in healthcare to combat the fact that a lot of times the price of a service is pretty opaque to the end user, to the patient, who is going to get the care, and then they don't know what it's going to cost them until after they receive the care. And so a lot of the push for price transparency focuses on this consumer price transparency piece, the idea that people who have high deductible health plans want to shop for their care and pick high value providers, but if they can't find the price ahead of time, then they can't do that. We hear about this price transparency, but we also think about it in a larger context of sort of consumer friendly billing practices where you might be able to get an estimate ahead of time, or the bill that you receive after the fact is understandable to the average consumer, things like that. So price transparency really gets at sort of the opacity of medical care in terms of its costs up front, but also it gets to this larger idea, which is I think pretty bipartisan, which is that if we are going to have people being active participants in the purchase of their own healthcare, then they should be able to act as consumers and shop around and know what things are going to cost ahead of time, be able to comparison shop and reward those providers who are providing high value care and use their healthcare dollars very wisely. So there is a lot of consensus that consumers need more information about the price of services, but it's not just consumers who use this information, it's also purchasers, plans, payers, employers, plan sponsors, but also the regulators and those in the government who are trying to understand, and sometimes at the state level, sometimes at the local level, what's going on in their markets, where the price is increasing and how's utilization changing over time. So those types of information is useful not just to a consumer, but also to a policymaker.
All right, well, there's been a lot of developments at the federal level in price transparency, including litigation. What's the latest?
Yeah, so there's been, this bipartisan, I mentioned this bipartisan push for greater price transparency. There are some lingering questions about what that means, and then I'll get into the litigation with that. And so there's this idea that price transparency could be, the charges that a charge master list. It could be the negotiated rates that that each plan negotiates privately with a healthcare provider. And that is, of course, the most useful information for a consumer would be their out-of-pocket costs, and that's very hard to get at. And then again, what is the type of charge that we're looking for? And that all leads to this notion that what consumers need are not just the charge master rates, which I think have been posted fairly publicly for some time now, but something that is more about the negotiated rates, the actual rates that a particular person with a particular health plan can expect to pay. And that's where it gets really touchy. So there was a final rule issued by CMS on November 27th, 2019. And the rule was just designed to promote price transparency. You might have heard news about President Trump issuing an executive order around last summer. And so the final rule followed the executive order, which came out in June of that year, that basically directed HHS to issue this rule. And so the final rule did come out in November. The final rule, the effective date of the final rule is bearing down on us. It's January 1st, 2021, which is just around the corner. And so there is a lot of consternation among the provider community about how to come into compliance with the final rule. So the final rule, and then I'll get into the litigation, the final rule requires all hospitals to publish 5 types of charges for each item or service provided by the hospital. And this includes, inpatient charges, outpatient charges, everything that would be on the charge master, essentially. So the hospital has to publish its gross charges, so the charge master rate. It also has to publish payer-specific negotiated rates. It also has to identify the maximum negotiated rate that it has, de-identified as to which payer, and also the minimum negotiated rate that the provider has, again, de-identified as to payer, as well as a discounted cash price for self-pay patients. And then for each of these, the hospital has to provide accompanying billing codes, whether that's the CPT code, the DRG, the HCPCS, and a description of what the charge is corresponding to. So I guess you can compare apples to apples across providers. So that is a lot of information that this final rule requires the hospitals to provide. In addition to that list, which is basically everything the hospital would provide on an outpatient or inpatient basis, the hospital also has to produce a consumer-friendly list, because you can imagine that list will have thousands of items long. Consumers, like patients, aren't going to be able to use that information very well. So each hospital has to publish a consumer-friendly list of standard charges, those same standardized charges for the 300 most shoppable services that the hospital has. CMS provides a list of some of the services that it considers to be shoppable, and shoppable services are just those services that are non-emergent, that patients usually schedule ahead of time. They may be able to choose among providers. You think of imaging, radiology, you think of MRIs, things like that, but also colonoscopies or knee replacements are things that you schedule ahead of time and that a patient could theoretically choose among different providers and shop for. So the hospital has to provide this information in a consumer-friendly manner for the 300 most shoppable services it offers. And if the hospital builds and maintains a consumer-friendly price, shopping website that allows consumers to go in a comparison shop, then it would be deemed to be in compliance. Now, if the hospital doesn't comply, starting on January 1st of this coming year, then there's a series of penalties. So the hospital could get a warning letter for non-compliance. If it continues to not comply, then it would have to enter into a corrective action plan with the agency. And then if the corrective action plan isn't followed, then the penalties accrue at a rate of $300 a day, and then also being named on sort of a shaming kind of list on the HHS website. So that's the final rule. It's a pretty heavy lift for hospitals in particular. And so, as you alluded to, Kerry, the American Hospital Association filed suit challenging the final rule, alleging that this final rule violates the CMS's authority. That it doesn't have the statutory authority to ask for negotiated rates, for example, just charge master rates, that it violates its First Amendment, the hospital's First Amendment rights, compelled speech, commercial speech, et cetera, and that it is arbitrary and capricious under the Administrative Procedure Act. So I don't know if you have any follow-up questions, or I could talk a little bit about where that litigation stands.
Yeah, before we get into the litigation specifically, we're all, in addition to being healthcare lawyers, we're also all healthcare consumers. And I think that we can agree that certainly we can appreciate that healthcare providers in general can do a better job of making it easier for healthcare consumers to figure out what their out-of-pocket costs are going to be. So from a policy standpoint, that I think everybody can get on board with. The questions that I get from our hospital members on almost a daily basis at this point as they're trying to comply with this complex set of new regulations is, why aren't the insurers having to do this? Because from the hospital perspective, the insurers are the ones that have all of this information. They're the ones that load the contracted rates into their databases to pay the claims. They're the ones that know how much each individual consumer or patient has spent down on their deductible. And so why, it seems like it would be easier for the insurers to provide this information to their consumers.
Yeah, so I think there are really only two sources of this information, the payers, the insurers, and then the providers. And so there is a lot of burden. The final rule really puts all of that burden on the providers, on the hospitals, and not on the payers. And it is a good question. You know, why do we turn only to the providers to provide this information as opposed to the insurers? And I think it is, you know, part of it is that it's just a matter of leverage. You know, HHS has more leverage over hospitals through the Medicare program and through its other sort of regulatory apparatus. So it doesn't have the same amount of regulatory authority over commercial payers in particular. You think about like employer plan sponsors or commercial payers, there isn't the same sort of lever as the Medicare program to say, okay, hospitals, everyone has to jump when we say jump. And so I think that is sort of just as a practical matter why the Trump administration's turn to hospitals to provide all this information is because of the degree of leverage and authority that CMS has over hospitals in general. And at the state level, you know, there is, we'll get into this in a little bit, there's another model called an all-payer claims database, which Georgia is in the process of implementing. But a lot of states have these all-payer claims databases, and that takes the opposite approach. That looks to payers to provide this information, not the providers. The providers sometimes provide that information, but primarily it's an all-payer claims databases for all the reasons you just said, meaning that the insurers, the carriers are the ones that provide this information to a state database, you know, on a claim-specific basis. And the reason why the payers aren't the ones that are, I think, turned to in the federal law is, I think, just that the idea of leverage, of where the statutory authority lies for HHS. The other issue with the all-payer claims database model or looking to payers is at the state level. I don't know if anyone recalls, you know, the ERISA case, the Gobet case from 2016 at the Supreme Court basically was about state all-payer claims databases, saying that the state of Vermont, and no state for that matter, can require self-funded employer-based health plans to report their data to the all-payer claims database. So the all-payer claims databases at the state level used to have more robust data and now are sort of missing a whole chunk of data, and that's all the self-funded plan data. Who can comply on a voluntary basis, but basically that data went missing after the 2016 case. So there's some problems with trying to look to payers for this at the state level. There's, you know, again, and then at the federal level, it's just a lack of the same level of granular authority over the payers that HHS has over the hospitals.
Yeah. The other question I get, again, almost daily at this point is the court gonna overturn the price transparency rule?
Yes, so let's talk a little bit about the litigation. So this summer, on June 23rd, Judge Carl Nichols, who's a Trump appointee at the U.S. District Court for the District of Columbia, who heard the case, ruled against the American Hospital Association's case and ruled in favor of the government, basically upholding this price transparency rule. The court concluded that the statutory requirement that hospitals report their negotiated rates, or the statute basically just says that the hospitals have to report their standard charges. And that's the word that everyone's trying to parse, is what does standard charges mean? Does that include negotiated rates? And the court basically said it's not limited to charge master rates, it includes negotiated rates. And the court rejected the First Amendment argument and also concluded the rule was not arbitrary capricious. So basically the Hospital Association lost on all three of its arguments. And so the AHA, of course, immediately filed an appeal and also filed a request for a delay of the implementation date, because as you alluded to, there's a lot of work and burden that goes into getting ready to comply with a rule like this. And so, hospitals clearly don't want to expend all of this resource if the rule is just going to be struck down at the Court of Appeals level. And 34 state hospital associations, including Georgia Hospital Association, signed a letter urging HHS to do this, to basically say, we're going to delay the implementation date to let the litigation run its course, so we don't have to, expend all these resources coming into compliance with the rule that, may get nullified at the next level. So there's no word yet on whether, I don't know if you've heard anything about whether there's any movement on that request, but as of now, the implementation date is still January 1st, and we still don't know when the appeal is going to be heard and when it's going to be decided. And so I think that puts hospitals in a really tough bind.
Yeah, unfortunately, no, we don't have any additional information about from CMS about taking us up on our recommendation that the implementation be delayed. And what we've been recommending to our members is that they move forward with the implementation process, because we don't anticipate that we'll get a decision from the Court of Appeals in time for them to, if we're on the losing side of that decision, in time for them to get ready for the January 1 deadline, unfortunately. Well, we're going to talk a little bit more later on in the day about some of the state legislation related to price transparency and surprise billing in particular. But I wanted to get back to the all-payer claims database for just a minute and ask you about how states are using them when they can get the information from the payers. From a policy standpoint, what are they using that information for? Who is getting access to it? And how has that had an impact on the providers?
Yeah, so all payer claims databases are these state-run, large-scale databases that systematically collect this type of healthcare payment and claims information from payers. So they are designed to really target payers, not providers, for this as the source of the information. At this point, I think 23 states, including Georgia, either have an all-payer claims database or are in the process of implementing one. And when we get into the legislative update later, I think that's part of the most recent session was the creation of the Georgia all-payer claims database. The way states are using them is they're using them for two primary purposes. The first is that consumer-facing idea of giving information, price comparison information in a way that's consumer-friendly, that a consumer who is having to choose a shoppable service, like an MRI, can go and actually comparison shop on price, but also on quality, to figure out what makes the most sense for them. And so that's been used by some states to promote this idea of sort of activated consumers. The other way states are using this information, or the purpose of it, is to really inform policymakers and regulators. So this is the way that the policymaker or the regulators at the state level can track utilization, can track price trends, cost growth, also establish benchmarks, again, for things like out-of-network surprise billing disputes. Any place where you need a benchmark that isn't covered by a contract, it's helpful to have statewide data of this level, and also identify whatever is driving cost growth in particular areas, and identify low value services and take steps there too. The other use of this, that states and regulators are using is for sort of public health purposes. So tracking things like opioid prescriptions, or and utilization of high value services or things like that also can be tracked through this information. So it is a useful amount of information. It tends to be, it requires a lot of data capacity on the part of the state. It's a lot of information coming in. So in order to glean anything useful from the data, you need sort of a bunch of people who know how to run data analysis. And it's sometimes one of the sticking points with these all-payer claims databases is that the information has to be, it's so big, but it also needs to be timely enough to be useful. Otherwise, if it's 3 years delayed, or even a year delayed, it's not as useful as it could be for consumers and for state regulators.
That sounds expensive.
Yes, it is, right? You build this new tool and then you need to hire people who are data analysts, and you need a committee of people to be able to track how to release the data when it's being requested. So who pays for an APCD differs from state to state. Some states fund it with general appropriations. Others fund their APCDs through particular fees on payers or on providers and payers. Others fund it through their Medicaid, some Medicaid funds. Some use federal grant dollars to establish an APCD and then establish user fees. Some use these user fees basically if people want the data, researchers and the like want the data, then they have to pay a fee to access, part of the data set in order to support the operation of the APCD. It's unclear how Georgia's APCD is going to be funded. The legislation basically just says that the director has to develop a proposal to fund the APCD and then present it to the governor and the General Assembly. So we don't have a clear plan, but there are lots of different ways that states are looking to pay for it. But you're right, it requires sort of ongoing commitment of resources.
Yeah, right. Well, we are getting close to the end of our time. Lane, do we have any questions in the chat?
We have no questions at this time.
Okay. Well, Erin, thanks so much for being with us today. Anything that you'd like to wrap up with?
No, I think that, I think this is just an area to keep an eye on. One of the things at the federal level is, of course, watching this litigation. But the Trump administration is doubling down on price transparency. This is something that has a lot of bipartisan support. It's not just something that the Trump administration is pushing. So, you might have seen there was another rule issued early in September about Medicare Advantage plans, and basically hospitals also have to disclose their their payer-specific rates with Medicare Advantage organizations in their Medicare cost reports. So this is not a trend that's going to go away, and so this is a front that hospitals and providers really should be prepared for. And then on the other hand, to keep an eye on the state level, the all payer claims databases, that the payers also have to be prepared to start getting ready to submit data. So everyone really has to start being prepared for compliance, because it is something that's coming down the pike, sort of regardless of whether delays can be secured. But I think this is something that's going to be part of the future no matter what.
Yes. Oh, and one question that has come in on the chat: does the price transparency apply to physicians?
I don't believe the federal rule requires price transparency from physician groups. However, hospitals, I think, that have affiliated physicians have to report that information, their outpatient prices as well, for the physicians that are part of their organization. So it's not as though independent physician groups have to report this information, but if a physician group is part of a hospital system and part of that inpatient and outpatient bundle of services, then yes, that their services would also have to be included.
Yeah, and that's actually one of the critiques I've heard about the rule, is that because depending on whether or not the hospital has physicians in their bundle of services, it's not necessarily an apples to apples comparison for a consumer that may be shopping for a service from hospital to hospital. All right, well, now that one person got started, we've got a couple more coming in. So we've got 1 more minute. Given the low fine for violation of the federal rule, $300 a day, do you think some hospitals will simply not comply and take it as a financial hit? Is there any violation for the fine or consequence? I'll answer this one real quick if you don't mind. I've heard that as a potential option. So far, I've only heard that from various consultants who have offered that up, that's a potential option for hospitals, particularly in cases where a hospital may be in have a very good negotiated rate with a particular payer that they don't want to disclose, and that the fine might be worth it to them in that particular instance for that one particular payer, so that it wouldn't necessarily be that they don't disclose all of their payer information, but that they don't disclose for that one payer. I haven't heard that from any hospitals in particular, although that's not surprising. I don't know that if somebody were planning to do that, that they would tell anybody ahead of time, but it certainly has come up. That may be the case from some of the consultants who were doing a lot of the education around this. And then the last question, what are the rules associated with price transparency for physicians who work in hospitals as independent contractors? I think we just answered that in response to the first question. So we are officially at the end of our time slot. I will thank you again, Professor Brown, for your time and your expertise on this. We could talk about this all day long. And I'm sure we will have another session on this post-lawsuit, post-implementation, and post-pandemic. So thanks again for your time.
Thanks, Kerry.
Thank you. I'm going to go ahead now and introduce our next speaker. Sean Sullivan is going to speak with us about telehealth and technology. Sean is a senior associate with the healthcare group at the law firm of Alston & Bird. He assists healthcare providers and business associates, not surprisingly, given our topic, in the areas of telehealth and healthcare technology. Sean has an interesting background. He has a Bachelor of Arts degree from the Emory University, where he double majored in political science and French language and literature. And he started his legal career after getting his Juris Doctorate from Georgia State University College of Law in the U.S. Army JAG Corps. So welcome, Sean. We're happy to have you. And this is certainly a timely topic given the pandemic going on. And really, unless you've been living both in your house and under a rock in your house, you will know that telehealth has just gone gangbusters since the pandemic has started. So certainly timely, and happy to have you here and learn more about it.
Thank you so much. I appreciate you having me, Kerry, and thank you for the introduction. Hope everyone can hear me. I assume
Yes.
Not getting any bad feedback, but good to know. Thanks for having me. So, like she said, I'm a healthcare regulatory at Alston & Bird, and I've had a focus in my practice for the last several years on healthcare technology issues, and in particular on telehealth. And you know, who knew that was a thing until seven months ago? But since then, it's been wild and it's been crazy. So, and moving very fast. So it's an exciting place to be. So that's what we'll be talking about today. I've got some slides. Let me try to put them here on the screen. There we go. So so I'll just go through. Like I said, Sean Sullivan. This is what we'll be talking about today. So I tried to focus it just on telehealth and telemedicine. There's a lot we can talk about as far as technology, and maybe that's for another time or place. But really, telehealth is a key issue right now that's facing healthcare providers and healthcare attorneys. They're counseling their clients as healthcare providers. So we'll be talking about the general legal landscape for telehealth. Then I'm going to talk a little bit about other sort of non-telehealth but technology-based healthcare services. Then we'll talk about the COVID-19 flexibilities that have been in place for the last several months, and then where is that going? What is CMS and other agencies trying to make permanent, and what are they going to make permanent in the physician fee schedule and in other rules that may be coming out as far as 2021 and going forward. And then we're going to talk about some of the enforcement risks and compliance concerns that can pop up when you're using telemedicine. So, you know, one big question, and this quote I think is key, hits it right on the head, is why can't healthcare, frankly, in general, be more like every other consumer-driven industry? Why can't it be consumer-friendly? Why can't you give the patients, the consumers, the healthcare consumers, what they want and what they need? And a lot of that goes to price transparency that we were just talking about in the last session. And then, a lot of that is being addressed now as the industry is finally moving towards this remote care, remote healthcare, just like we've had in banking industry, financial industry, and lots of other industries for a long time. So what is the current regulatory landscape? And now, just to be clear, most of what I talk about in this first section is going to be related to the current, the pre-COVID rules, and then we'll talk about the COVID rules later on. But pre-COVID rules, so typically when you're looking at telehealth, you need to look at the state where the patient is physically located. And that is where the healthcare practitioner, the physician, would need to be licensed. There are some exceptions to that. Georgia just passed the Interstate Medical Licensure Act, and there's several other states that have now passed the Interstate Medical Licensure Act. There's other states that have exceptions for things like adjacent states or occasional non-routine visits or consultations and things like that. So there are some exceptions, but typically you're going to be looking at the licensure rules where the patient is located. Scope of practice. So it is important that you, first of all, establish the valid provider-patient relationship, which we'll talk about a little bit more. And some states do, in fact, have some specific rules on what can or cannot be done via telehealth. Not so much in the physician medical practice space, although there are some restrictions depending on the state. But a lot of times you might see that in other types of professions, like for teleoptometry, for instance. Only these types of visits may be conducted via telehealth. So it is important to know and understand the scope of practice. But typically it is going to be the scope of practice that is key is what is clinically appropriate based on that physician or that practitioner's professional judgment. And so you're looking at the same standard of care that would be in-person treatments. I gave you the one for Georgia. The standard of care is what, under similar conditions and like circumstances, is ordinarily employed by the medical profession generally. So that's the standard of care that you're going to be looking at in telehealth, the exact same standard of care that you'd be looking at for an in-person visit. Establishing the provider relationship. This is something that a lot of providers kind of gloss over, but it is important that that the practitioner relationship is, in fact, established in a valid way. Many states have specific rules, and many professions in those states have specific rules on what must be done to accomplish that physician or practitioner relationship via telehealth. In Georgia, you must have either personally seen the patient, provide care at the request of someone else, or be able to examine the patient using technology or peripherals that are equal to or superior to an examination that is done personally by a provider within that provider's standard of care. So it's a key that the provider-patient relationship is back established. So prescribing, many states and the federal government have restrictions on prescribing controlled substances. Georgia just recently, I put the blue underlined text is what the rule was recently amended to state. I think it used to be a 72-hour supply. Now telehealth can be used to prescribe up to a 30-day supply of controlled substances, or if there is a valid physician-patient relationship that already exists. Now there's also a federal law, the Federal Ryan-Haight Act, that states that controlled substances cannot be prescribed without at least one in-person evaluation, except under a number of exceptions. One of those is if you're practicing at a facility that has a DEA registration, like at a hospital, and another one is if the practitioner has a special registration for telemedicine. And this has been an area of controversy in the telemedicine industry for a long time because the DEA has never published regulations to establish what is that special registration for the practice of telemedicine. That's something to keep an eye on. It may come out sometime in the future. But one other exception that is important for us to remember right now is that controlled substances can be prescribed pursuant to federal law under a public health emergency. So we'll talk about that more later in the COVID-19 arena, but it's important to note that there are these federal restrictions as well as state restrictions around prescribing. So Hipaa, of course, still applies under when providing services via telehealth. The kind of key areas that you'll look at is make sure that you have that the provider has a business associate agreement with the technology vendor, with the telemedicine or the technology platform, and that they have reasonable safeguards to ensure that incidental disclosures are kept to the minimum necessary. Now, there are stricter requirements for certain types of settings or certain types of records, such as psychotherapy notes, which require specific patient authorization in almost every circumstance. And then FERPA, the Family Educational Rights and Privacy Act, has basically there's not the same sort of broad consent exception for treatment payment and operations under FERPA. So it's important to keep that in mind. And then informed consent. So many states do have specific rules, and it may be particular to a specific profession, but there may be a written informed consent requirement there, and there may be certain elements that need to be part of that informed consent. So if you're advising a telehealth client that is rolling out a telehealth program, whether it be, again, teleoptometry, teledermatology, telephysical therapy, whatever it might be, you really need to be careful to look at those rules in that state to ensure that you craft a written informed consent document or process that meets those requirements, that hits all of those elements. So billing and reimbursement, this is really the most important thing for most providers. How are we going to get paid? And Medicare has these very specific requirements, again, in a non-COVID-19 era. Medicare's got basically 5 elements, 5 requirements. First, there must be a rural geographic location. The originating site must be one of a number of listed sites that are listed in the statute. So those can't be changed by regulation by CMS. Places like a physician office, hospital. There must be one of a listed number of distant site providers. This is the provider providing the telehealth services. Physician, nurse practitioners, physical therapists are on that list, and there's no location requirement. They don't have to be in any specific location. The geographic location is really a location for the originating site where the patient is located. Fourth, there must be a qualifying technology, which is a synchronous, live, real-time audio, video communications connection. And the regulation previously said, there's some regulatory flexibility around this, but it specifically said no telephone, no email, no fax. And then fifth, must be a telehealth covered service. And CMS typically amends these and adds new services to the CPT code list every year. At the beginning of the year, there were 101 services. And then there's an originating site facility fee. So if they're in one of those eligible originating sites, there's usually a $20-something originating site that is meant to reimburse that facility for the cost of the infrastructure, technology, maybe having a nurse or a technician, rolling the cart in, things like that. And billing and reimbursement for, I skipped 2 slides there, for Georgia Medicaid. So Georgia Medicaid has a lot of the same requirements, some of the same elements, but what is different is that Georgia Medicaid doesn't have that rural geographic location limitation. Georgia Medicaid does require informed consent, and they actually provide specific guidelines on what needs to be in that informed consent document. And Georgia also says that there must be a Hipaa compliant method of communication. And I was just refreshing on this, and they actually updated their manual on October 1st, 2020. So if you are doing anything with Georgia Medicaid related to telemedicine, then do take a look at those updated requirements in the new manual. So for private payers, private payers can kind of run the gamut, but most states have some law on the books that mandate that telehealth must be reimbursed when paid for by private insurance carriers. And these come in 2 flavors. One is equal coverage. And equal coverage means that if it is a service that is a healthcare service that is covered when it is provided in person, then it should be covered in telehealth when provided via telehealth as well. There's sometimes wiggle room around the way those statutes are written, but that's essentially the equal coverage flavor. The other one is equal payment, and Georgia just moved over to this. Last time I checked, this may be out of date because this was a couple months ago, but last I checked, there were only 6 states that fell into the equal payment category, and that basically states that if there is If a service is reimbursable in person, then it must be reimbursed and reimbursed at the same rate if it is provided via telehealth. So this is, and I provided a sample of what the new Georgia statute says in this regard. So there are other services that are not technically considered telehealth as far as Medicare is concerned. Sometimes they're thought of in the industry as telehealth, but they're not specifically Medicare telehealth services. These are things like remote patient monitoring, which Medicaid covers in most, or maybe not most states, 22 states last time I looked. The way Medicare covers it is there's basically 3 different charges. One is to set up the device, one is to provide the device, and then one is for the professional time to provide coverage of monitoring that device. Again, that's not considered a telemedicine service because it's inherently not face-to-face, but this is something new that's been, these RPM services, also sometimes referred to as chronic care management or remote physiological monitoring. This is new within the last couple of years, and a lot of providers are just starting to wake up to it. It can be great for patients to just provide sort of constant oversight and monitoring, and it can provide an extra revenue stream for providers as well. So virtual check-ins, this is another relatively new code. Again, there's 2 codes for it. Because it's not a Medicare telehealth service, it's not limited to rural settings. It's not limited to real-time audio video connections. This is something that can be done typically over the phone, can be a virtual check-in, and then the store and forward for video and images, that can be basically, an emailed video or photo that you take and send it to your physician, and they can evaluate and actually get reimbursed for it now. And e-visits. So e-visits, again, fairly new. This is basically a communication via the patient's or the provider's online patient portal. There are a couple different codes. There's some that are reimbursed at a slightly higher rate for those that are eligible for telehealth services, basically the providers that can bill E&M services like physicians, nurse practitioners, physician's assistants. And there's these other codes for those other types of providers like physical therapists, occupational therapists, speech language pathologists. I believe psychologists would also be in there. And they can use these other codes, the G2061 through 2063 codes, to provide services and be reimbursed for these e-visits. So that was kind of a quick refresher on where we were as of February of 2020. But what about now? How has the world changed, and how have these regulations and requirements changed over the last 7 months or so? Well, first, as a refresher, kind of a summary, these are the Medicare telehealth reimbursement rules. This is, I think, the slide basically exactly the same as the slide that you saw a few minutes ago. But how has this changed? So now that geographic location based on a temporary waiver has been waived. It no longer has to be, during this public health emergency, no longer has to be in a rural site. The originating site has been waived. Telehealth services now can be reimbursed by Medicare and provided in the patient's home or in any other location. So that originating site location has been waived during this current public health emergency. The distant site provider, this was actually a statutory waiver, which took some effort to allow that waiver to happen. But now providers that were no longer permitted, such as physical therapists, occupational therapists, speech language pathologists, can furnish Medicare reimbursable telehealth services. That qualifying technology, CMS has put out a temporary regulation that now waives that video requirement for 89 specific services, and that list can be added to as well. So there's 89 services they now list as Medicare telehealth services that can be provided via telephone-only connection. And then they've also removed that reference to no telephones in the regulation, because what they're saying is that we realize that smartphones can have a real-time audio-video connection. So they've temporarily permitted that, and we'll see that reference to telephones is likely going to be removed permanently. And then they've also expanded that covered telehealth list from 101 services to 238 services now. So it's quickly grown quite fast in response to the public health emergency. And the last point, I think, is very important and something that is often overlooked, but now that originating site facility fee that can be billed by hospitals, physician practitioners, and other places, it obviously cannot be billed when a patient is at their home, because there is no, you can't, the home cannot be a Medicare enrolled entity. So instead, what they have done is they say now if the service is being provided in a non-facility location, then the practitioner, the provider, the distant site provider can bill it as a non-facility service, and they get increased reimbursement because the practitioner there is basically bearing the cost of the infrastructure and the additional technology of being able to provide telehealth to the patient's home or to some other location that is not a, an eligible site like a hospital or physician practice. So some of the other typical telehealth requirements, these are some of the things I went over a couple minutes ago, but how have these changed? Well, frequency limitations, I didn't mention this before, but typically inpatient hospital visits are limited for telehealth to once every 3 days. Nursing home visits are once every 30 days. Those have been waived during the public health emergency. Medicare has also stated that the licensure requirement that the practitioner is licensed where the patient is located, the Medicare has waived that, and they no longer worry about that during the public health emergency on a temporary basis. However, you still have to look at state requirements. But most states have done something about that. Many states have enacted temporary regulations, or they might be executive orders, and some states even legislation that completely waives the licensure requirement for services provided in their state during the public health emergency. Other states have enacted an expedited process or some sort of quick registration or notice to the medical board. But it's helpful to note that has been waived on the Medicare side, and most states have done something about that as well. So like I said, for prescribing controlled substances, the Federal Ryan Hate Act is very limiting in most circumstances, but there is an exception for public health emergencies. So we have that now. OCR has also announced that they will not be enforcing Hipaa for telehealth services during the public health emergency. And the OIG, which typically enforces the anti-kickback statute and other fraud and abuse rules, has announced that they are not going to enforce the typical copay and cost-sharing requirements for Medicare beneficiaries for services provided via telehealth, again, during the public health emergency. So other remote care limitations, direct supervision is typically something that is required for Incident 2 services. What they have done now, again, the red is the temporary regulatory flexibilities or statutory waivers pursuant to the public health emergency. CMS has said that direct supervision, which typically requires the supervising physician or supervising practitioner to be in the same office suite and immediately available to assist, now they can provide that direct supervision virtually, as long as they have some sort of availability to connect with an audio-video connection. The same as applied for certain hospital outpatient therapeutic services that would normally require direct supervision. Those may now be provided via virtual direct supervision. One of the requirements for remote patient monitoring typically is that to bill a month of it or to bill 30 days of it, there must be at least 16 out of those 30 days that must have had active monitoring. Now, CMS during the public health emergency has said that there is a minimum 2 days, so only 2 days out of 30 days, as long as it is a suspected or confirmed COVID-19 patient. And then one of the other requirements for some of those non-telehealth remote services like virtual check-ins and remote patient monitoring is that there is a pre-existing practitioner relationship. CMS has said that they will not be enforcing this pre-established pre-existing relationship during the public health emergency. So a lot of changes there, and there's been a lot of talk in the industry over the last several months about what is going to stick and what's not going to stick. And most in the industry, both from CMS down to providers alike, agree that we really need a lot of these things to stay permanent, because the industry has moved so slowly over the last 10 years moving towards telehealth. But now this has been a huge change, and people like it. And it reduces hospitalizations, and people enjoy being able to and appreciate and save so much time being able to access their practitioner remotely. Seema Verma, the administrator of CMS, says it would not be a good thing to force our beneficiaries to go back to in-person visits after the public health emergency. So in the physician fee schedule proposed rule, which typically comes out every summer to go in effect the following year, this came out in August. There was also the outpatient prospective payment program system proposed rule that came out around the same time that enacted some of these changes. But they're going to make some of these temporary public health emergency changes permanent. So what specifically are we talking about? Well, they've basically ballooned the number of services that can be provided on the Medicare telehealth list permanently. They added, like I said, we went from 101 to 238 during the public health emergency. Many of those are going to remain on the permanent side for the telehealth list. And then they also said that many of them are going to be temporarily added, and those will be temporarily added not just during the public health emergency, but for the remainder of the year that the public health emergency ends. So if the public health emergency ends in January, which I think has already been extended to January, then all of 2021, these new services will be on that temporary list to give CMS an opportunity to think about and relook at and get comments and feedback on whether or not these services like domiciliary rest home or custodial care services, home visits, emergency department visits, whether these types of services should be made permanently available to the Medicare telehealth list. And then there were a handful of services that did not make the permanent list. Again, these are proposed rules, so there was still the opportunity to comment. I think the comment period closed on October 5th. But these services that I've listed here are the big losers. You know, these were available during the public health emergency, but they're not going to be available in 2021 after the public health emergency ends. For inpatient nursing facility visits, I think this is key for certain parts of the industry, and there was always this initial visit that was required for nursing home visits that had to be done in person. This was waived during the public health emergency. CMS says that they are considering waiving that on a more permanent basis. And then they have also reduced on a permanent basis the frequency limitation for nursing homes, which was reduced from once every 30 days to now once every 3 days under the proposed rule. They did not go back on the hospital frequency limitation, so they are planning to put that back at once every 3 days for hospital services to be provided via telehealth. So technology, like I said before, CMS recognizes that smartphones can provide real-time audio-video connections and do so very well. So they are permanently removing telephone, that reference to telephones in the regulation. And direct supervision, they've also proposed to make this direct supervision to be able to allow it to take place virtually. They propose to make that extend into 2021 and for the end of the calendar year in which the public health emergency ends. Again, it's subject to the clinical judgment of the supervising physician, so it really is based on what is clinically appropriate. And they also clarified in the rule that there does not need to be a continuous open audio-video line between the supervised practitioner or technician or whatever it might be, that there can just be, the supervisor must be immediately available via an audio-video connection. And they've also clarified that these telehealth services can be provided incident to a physician services. So basically, you can have virtual supervision of a nurse practitioner providing telehealth, so almost 2 layers of telehealth. But they've clarified that yes, you could certainly do that under these rules. And the virtual supervision also applies to these certain hospital outpatient therapeutic services like pulmonary rehabilitation, cardiac rehabilitation, intensives, cardiac rehab services, again, subject to the clinical judgment of the supervising physician. They've also implemented some more permanent rules regarding remote patient monitoring. Consent, this was part of the public health emergency. Consent can be obtained at the time that the RPM services are proposed. They've also stated that RPM, well, these last 2 bullet points are 2 things that they are not proposing to make permanent pursuant to the public health emergency after the public health emergency is over. that RPM services, again, will only be available to pre-existing patients, and that there must be a minimum of 16 days out of 30 in order to bill for remote patient monitoring services. And I thought this was helpful. It's potentially limiting, but CMS did finally provide a little bit more guidance on what constitutes a remote patient monitoring device. They had previously said, I think several times, that they will provide guidance in the future on what is an appropriate device. And all they had said is that the remote patient monitoring device must be an FDA, must be defined as a medical device under FDA guidance. Not that it had to be FDA approved, just that it was defined as a medical device based on the FDA's definition. But now they've said that that device should digitally, that is automatically, upload patient physiological data, and that the data cannot be self-recorded or self-reported. So I thought that was helpful, at least gave us a little bit of guidance where there was none before. They've also expanded on these communication technology-based services. These are the inherently remote non-telehealth services. They have now proposed new codes for physical therapists, occupational therapists, other types of practitioners that could not typically bill E&M services or telehealth services, that they will now be allowed to do these remote assessments of video and images, virtual check-ins, and e-visits. And important to keep in mind that there are appropriate modifiers that should be used for those types of codes. And the side of service differential, I explained this before, how if a service is being performed via telehealth in a non-institutional or non-facility location during the public health emergency, then a practitioner can bill using the non-facility code and receive an increased reimbursement rate. For example, I gave this example of 99212 that's billed at a facility rate that's $26, but then the facility, the hospital or whatever the patient is, can also bill that $25 originating site fee. That originating site fee may not be available if you're providing services to a different type of location. So this is one thing that I think that CMS had a big whiff here, a big miss, but they have not provided any guidance on how to use the place of service code and what type of reimbursement differential there might be for non-facility versus facility rates. So we'll see how this shakes out when the final rule comes out in the coming months. So just as a summary, this is a slide I showed earlier, but these are all the waivers and flexibilities, whether they be regulatory flexibilities on a temporary basis or statutory waivers. This is what we've seen for the last several months for Medicare telehealth reimbursement. And many of those that I didn't talk about in the last couple of minutes are going to require legislative changes. So these are some of the ones that are going to require a legislative change because these are hard baked into the Social Security Act. That originating site requirement that says that it must be a rural area and also says that it must be a specific type of facility like a hospital or a physician practice or something like that. Those are part of the statute. CMS cannot change those, so we really need legislation to make that change. Also the type of practitioner, again, there's a number of listed practitioners. Physical therapists, occupational therapists, speech language pathologists are not listed, and there's been a huge outcry among that industry, that segment, trying to get those to be added to the list, but that's something that would require congressional change. There was a coalition, I've put a copy of it here on the screen, there was a coalition of industry groups, health systems, providers, other types of providers, that wrote this letter to urge Congress to take this up and make some of these changes that are pursuant right now to a public health emergency statutory waiver to make them permanent. We have not seen any changes, and we haven't seen much legislation take place at all over the last several months. So we haven't seen any changes, but something to keep an eye out for. Hopefully there will be some movement in that regard to help out our providers and patients seeking telehealth services. So what can go wrong? We spent a lot of time talking about, first, the regulatory environment, second, all the changes that have happened over the last couple of months, and it's hard to keep up with. It's hard to keep up with for a lot of clients that I work with, and it's hard to keep up with from just folks I'm hearing in the industry. And where can they go wrong, and where do us as lawyers come in? Well, there's a lot of technical rules that are important for healthcare attorneys and especially health IT attorneys to be mindful of. there's the payment in full and anti-supplementation rules. And as I discuss these compliance risks, enforcement risks, I'm going to go from kind of more benign to, a little bit more, more criminal-like potential penalties. So first we'll start with these sort of technical rules, technical risks. So the anti-supplementation rules, these are often implicated when you have a hospital that provides a subsidy or provides a guarantee. Basically, the rule states that a provider may not seek additional payments beyond what is available under Medicare or Medicaid from any other person other than the cost-sharing obligations. So that's obviously implicated when you have an arrangement. Oftentimes, you have a telehealth practice, maybe a physician practice that provides telehealth services to a hospital, and the hospital guarantees a certain amount to that physician practice, but the physician practice also bills Medicare and or Medicaid or other payers on their own. But the way that you kind of deal with this is a subsidy or a guarantee or something like that is typically going to be viewed more favorably, is typically going to be acceptable if it's not tied to a specific patient or a specific service. So if the payment is X number of dollars per month or a minimum of so much, in order to guarantee availability, clinical integration, high quality, things like that, and that's typically going to be acceptable. What is a little bit more frowned upon, which could trip these rules, would be if for every service that you provide via telehealth to a patient in this hospital, we'll provide you 10% more of whatever Medicare bills, or we'll provide an extra $15 subsidy for every service that's provided. So that's where you can trip over these payment in full and anti-supplementation rules. There's also very technical requirements for inter-jurisdictional reassignment. These are in the Medicare manuals. They're located actually in a couple of different Medicare manuals, and I won't get into the details of them at this point. But as you can see from this graphic, there are different Medicare administrative contractors all over the country. So what happens when you have a practitioner in Oregon and a physician practice in California and maybe a patient in Texas? So you've got 3 different MACs that are in place, or at least 3 different areas. So you have to be very mindful of what entity needs to be enrolled in what MAC and what MAC to send the bill to. And there's technical requirements about that, and all of it is permitted as long as you follow the rules. And then the Ansi markup rule, this is not typically implicated for most telehealth arrangements, but I thought it's important for folks to know about because this does come up with teleradiology programs. Essentially, the Ansi markup rule states that a provider cannot mark up diagnostic services for providers that don't, quote, share practice with the billing provider. And sharing a practice has specific requirements on what sharing a practice means, but this is something to be mindful of, especially for teleradiology programs. So establishing the physician-patient relationship, I may have mentioned this earlier, that this is often overlooked by a provider, actually creating that physician-patient relationship according to the minimum requirements in state law. It's key for both the physician to be comfortable that there is a relationship here and that the physician understands what is clinically appropriate via telehealth and can I provide this service according to my standard of care, which is the same standard of care in person when I'm providing it remotely. And then also on the other side, the patient needs to be comfortable with the service. So you really have to have buy-in both from the provider and from the patient when establishing these physician-patient relationships via telehealth. And also it's important to be mindful of patient complaints. Some states in particular actually do require, as part of their informed consent for telehealth requirements, they say you must provide the patient with how they can make a complaint to the medical board or to the professional licensing board as part of the informed consent process. And billing for emerging technologies is certainly a risk. We've spent a lot of time over the last 40 minutes or so talking about the changes, and these changes have happened rapidly. And even not in a COVID environment, the changes still happen rapidly, whether they are telehealth or remote patient monitoring, which changes the guidelines for billing RPM services seems to change annually, if not more often than that. So because of these rapid changes, both on a state level as well as a federal level, it's just very, there can be risks if you don't have a good compliance, if a provider doesn't have a good compliance program, have a good understanding of the billing regulations, and frankly have a good communication line with either a good billing consultant and or a healthcare regulatory attorney that are on top of these. So consultations, this is an area where risks pop up from time to time, and what I'm talking here is oftentimes second opinions or specialist consults. So when the provider that is providing care directly to the patient needs a consultation, and they may call a specialist provider on the phone. They may also do a telehealth visit where the specialist actually looks at or does some type of evaluation of the patient. Sometimes these are not billed. Sometimes these can be billed. This last bullet point here says Medicare recently added a code for these remote interprofessional consultations. But sometimes these are billed and sometimes they're not billed. These can lead to, oftentimes can lead to liability or malpractice concerns. And the way to address that is often overlooked by providers is by writing down in either in the patient's record if the consulting provider has a patient record on that patient, which would be the optimal case. But if they don't, then they need to log it somewhere. They need to log that discussion somewhere. Because what if the provider's patient thinks they heard one thing, but the specialist thinks they told them something else, and there's a disconnect there. So it's paramount that both sides, especially that consulting physician, documents what advice that they've given, and whether that be in the patient record or some sort of other log. That's still a key consideration. So HIPAA, of course, this is something that the providers can trip up on and have tripped up on. I do a lot of regulatory diligence on deals, and oftentimes find providers that have technology agreements, technology telemedicine platforms that they use, and sometimes they don't have business associate agreements. I mean, frankly, frequently they don't have business associate agreements with these technology providers. So there should be a business associate agreement with the technology provider that is providing that service, that is hosting the telemedicine. Now that is waived currently during the public health emergency, but just because the enforcement of that is waived doesn't mean that the risk of a potential breach is gone. So still important that the provider does these, ensures that there's a valid business associate agreement there, and that there is notice of privacy practices on both sides. So every side needs to know who is providing the patient with a notice of privacy practices. Again, if you have a hospital and you have a telemedicine provider and the patient's at the hospital, who actually provides that patient with the notice of privacy practices? You just need to be on the same page as far as that. And I've seen litigation arise where both sides thought that the other side was fulfilling the HIPAA obligations when providing services to the patient, and frankly, neither side was providing a notice of privacy practices or was really being mindful of HIPAA at all. So these are key components to remember when developing telemedicine arrangements, when developing when agreeing with technology vendors or with others to think through these issues and make sure you do have appropriate indemnification provisions. So EMTALA, as we know, EMTALA generally requires that anyone that comes to an emergency department, they be stabilized and treated regardless of their insurance status or their ability to pay. Part of those requirements is that you must have on-call physicians that are available, and those on-call physicians must be available to come in. And then you also, this is for hospitals in particular, the hospital must have on-call physicians, and then the hospital must also have a backup plan if there is a physician that is on call that cannot come in. Well, I've gotten a lot of questions from hospitals that say, can't we use telemedicine to fulfill our EMTALA obligations? And the answer is yes and no. You can use EMTALA you can use EMTALA for that backup plan, to fulfill your obligations, to have a backup plan, to consult with another physician, to exchange imaging studies, to have a consulting physician, something like that. But where the challenge comes in is if that telemedicine physician is also on the on-call list, then if the telemedicine physician needs to come in for some reason, because the patient needs to be seen by somebody, but the telemedicine provider is on the other side of the country because they thought they were only there for telemedicine, then that could be an EMTALA violation. So the hospital needs to be very clear about who is on their on-call list and available to come in on call if needed, and who is part of that backup plan, maybe available via telemedicine, maybe available for consultations, but cannot come in. So those have to be two very distinct lists. So the anti-kickback statute, Stark Law, there have been a number of OIG opinions that have looked at telehealth arrangements. Oftentimes these are in the context of providing free or discounted services to hospitals or to physician groups in the form of telehealth technology or a telemedicine on-call arrangement, or providing a rural hospital with with telehealth availability, telehealth coverage, and providing that on a free or discounted basis. And optimally, a provider and their counsel would structure any of those types of telehealth arrangements to comply with the applicable anti-kickback safe harbor or Stark Law exception. But not always can that be done. Luckily, the OIG, every single time that they've reviewed these types of arrangements, and I've listed the 5 here, the OIG advisory opinions, they've found favorable circumstances because of a number of safeguards. So typically these safeguards that are incorporated in these types of arrangements, which you will need to think about incorporating if you are advising a hospital client or some other healthcare client on developing a telehealth arrangement that may not meet the personal services safe harbor or the equipment safe harbor or the applicable START exceptions. Some of these safeguards are things like patient freedom of choice, no advertising for free services, follow-up referrals are sent to other primary care physicians, and of course, a public benefit. And I think that's one of the key points that OIG leans on and that is important for these types of arrangements. These are often providing much needed services to rural locations that otherwise would not have access to certain types of medicine and certain types of specialists. The OIG did come out with, it was a couple of years ago now, but there was an OIG report. They did a relatively small scale audit, but they did a report on telehealth services and which telehealth services met the requirements. The 5 requirements that I talked about before: originating site, distant site practitioner, rural originating site, all of listed on the CPT code list, those requirements. And interestingly enough, they found that 31% of the claims sampled did not meet the Medicare conditions for payments. The vast majority of those were because the beneficiary was at a non-rural originating site, and I see this with clients all the time. Those rural designations change, not that frequently, but they do change from time to time. So maybe a provider, a hospital thought that they were in a rural site years ago, and they no longer are in a rural site. So there can be a lot of confusion around that, and it's important for hospitals especially to know when they're providing services via telehealth, whether it's an eligible originating site or not. So what CMS recommended here is that they recommended a number of audits, post-payment reviews for disallowing payments, and to work with MACs to implement claims audits. And since then, this was in 2018. We have certainly seen an uptick in enforcement actions in both on the OIG side as well as criminal enforcement actions by the DOJ. So there's certainly been a lot more attention to telehealth since this report came out, and I think it's only increasing. And they also published recently, I believe this was earlier this year, that OIG would be auditing or reviewing telehealth services in the Medicaid managed care space for behavioral health services. They're focusing on specific states, identifying those states, identifying certain managed care organizations, and they're conducting an audit as we speak. So this is certainly an area of attention for OIG and federal regulators. So wanted to touch on a couple of cases here. This is one that's a couple of years old now, but this is an example where a psychiatrist here was prosecuted, had agreed to pay a significant fine for services that were simply provided over the phone. So they may have otherwise been eligible, but they did not meet the definition of telehealth for Medicare, did not meet all of the requirements because there was not this live audio video connection, and it was prosecuted here. And this was one of the more significant recent prosecutions back in 2016. But more recently, the DOJ, and in particular the Southern District of Georgia, has been doing a lot as far as enforcement of telemedicine and telemedicine fraud. The first big one to report was Operation Brace Yourself. This was announced in April of 2019. This was durable medical equipment, and you'll see durable medical equipment as a recurring theme as we go over a couple of these. There was over $1.7 billion in claims, and were paid over $900 million. So this was, again, announced in 2019, and the results of it was that the CEO in Savannah was sentenced to 40 months in prison and had to repay almost $2 million. The telemedicine company that was implicated was ordered to pay $200 million in restitution. So significant penalties, jail time for companies and individuals that are involved in these fraudulent telemedicine schemes. And we'll find out more exactly about what was going on in these types of arrangements. But it is a significant enforcement area for the Department of Justice in general and in Georgia in particular. So Operation Double Helix, this was one again earlier this year or it was in 2019, so recently. This was a telemarketing company that was offering free genetic tests to patients with family history of cancer. The doctors wrote prescriptions for the genetic test, but then never sent the results or gave consults to beneficiaries, simply dropped the claim to Medicare and were reimbursed. And then they split those charges between the patient recruiter, the doctor writing the prescription, the lab, and then the telemarketing company that organized the scheme. There were charges among dozens of individuals, including 9 doctors, and the Department of Justice said that it cost the Medicare program more than $2 billion in unnecessary charges. So this is why you can see this is a significant enforcement area. We're talking billions and billions of dollars that are going into these schemes that have telemedicine really at the heart of them. And then Operation Rubber Stamp was announced just a week or two ago. So September 30th. Very similar, a large part of it was related to durable medical equipment. This quote, that telemedicine can foster efficient, high-quality care when practiced appropriately and lawfully. Unfortunately, bad actors attempt to abuse telemedicine services and leverage aggressive marketing techniques to mislead beneficiaries about their healthcare needs and bill the government for illegitimate services. This quote was from the HHS Deputy Inspector General, Gary Cantrell. So in case you thought that regulators were distracted, this was just 2 weeks ago, were distracted by the coronavirus, or that enforcement, was happening elsewhere in the country, Georgia really is a hotbed of it, and they're pushing hard on it right now, even as we speak. So this is a part of the Operation Brace Yourself announcement that was from Savannah News just a couple of days ago.
It is costing taxpayers like you billions of dollars, and tonight the Southern District of Georgia says our area is at the center of a scheme involving telemedicine fraud.
A nationwide crackdown called Operation Rubber Stamp is happening now. WSCV News 3's Kelly Antonacci is on your side with what's involved.
When we stand up here together and we stand up here unified.
Standing with U.S. Attorney Bobby Christine and federal agencies, U.S. Attorney Peter McCoy says they're putting an end to telemedicine fraud, especially in their jurisdictions, the Southern District of Georgia and South Carolina.
On a basic level, these individuals and companies collect patient data. The data then is used to generate fraudulent orders or prescriptions. The package of patient identifiers and fraudulent orders are then sold to the highest bidder, consisting of durable medical equipment companies, pharmacies, or sometimes other middlemen.
Those people then fraudulently charge healthcare programs like Medicare. In our region, those charges have added up to $2 billion. That makes up about 50% of fraudulent billings nationwide.
And it's not just in the Southeast, it's nationwide. And for people that think this is not happening in their state or not happening in their backyard, that's just a wrong assumption.
42 people have been indicted so far. It includes medical professionals, marketers, and telemedicine companies. If they're guilty, it could mean a 30-year prison sentence.
Be careful giving out your health information on the phone, especially to telemarketers. Look for unusual items paid by your insurance, particularly Medicare.
Prosecutors say telemedicine fraud is still happening and their investigation is still ongoing. Kelly Antonacci, WSAV News 3, on your side.
The Department of Justice says 86 people have pleaded guilty to telemedicine fraud across the country, and together they submitted more than $4.5 billion in fraudulent claims.
I thought that was a particularly
it is costing taxpayers
particularly timely news story for all of us, especially as we're studying telehealth and the expansion of telehealth and the quick expansion of telehealth over the last several months. There's still these very real enforcement risks, especially for fraudulent actors. But as I discussed at the beginning, there are a lot of technical risks and potential footfalls that can take place when developing a telemedicine program. But what are we looking for and what do we look at in these recent Department of Justice cases? You know, there's some common threads: lack of medical necessity. Oftentimes, these are telemarketing companies that simply call a patient, collect their information, send that information over to a bad acting physician that writes a prescription for DME and then sends it to the patient, or doesn't send to the patient. But there's no medical necessity there. There's often payment of kickbacks to these telemarketing companies, and often taking advantage of rural or vulnerable populations. So just to kind of wrap things up, you know, where do we see the industry going? It's certainly changing a lot, and I think we're going to see the industry of telehealth in particular and healthcare in general moving more and more towards a consumer-driven, consumer-friendly type of model, and telehealth is going to be the key to that. Certainly, a lot of services still need to take place in person, but there are so many services where a patient, maybe a rural patient that may be hours away from a hospital, does not need to drive 3 hours to, you know, talk to their physician, when it could be done over the phone or could be done via an audio-video connection, where nobody had to wait, nobody had to sit in a waiting room, nobody had to be exposed to COVID-19 or anything else. And that's the way we're seeing the industry going. And I think that we've seen massive movement over the last couple of months with COVID, and it's been great for the industry. It's been a blessing in disguise. And as I discussed with the COVID-19 flexibilities and the proposed physician fee schedule, some or maybe a lot of it is likely to stick for some time. So what have we talked about today? Talked about, again, telehealth legal landscape. I've pre-COVID talked about some of the remote patient monitoring and other types of remote communication-based healthcare services, the COVID-19 flexibilities that we've had in place for the last several months, as well as what is likely to stick, what is likely to stay in the physician fee schedule, and then the enforcement risks. So that wraps it up for everything that I've got prepared today. Thank you. I don't know if we have any time. It doesn't look like we really have any time for questions. I may take one or two, but I will take a look at any questions that were submitted. Feel free certainly to reach out to me if you have any questions or want to comment on anything, but I'll take a look at anything that was submitted, and I'll try to follow up afterwards as well.
Sean, thank you. That was excellent. And I actually have a really quick question. Kerry may want to weigh in as well, but before I get to that, there have been a lot of requests for your slides, which were excellent. Those will be sent around after the panels today, so you should receive an email. If you don't, please reach out. We'll make sure you get it. But the question I have, and you covered this, is, you brought up, one of the biggest hurdles that we have with telemedicine is the originating site and the role requirement, which, as you said, CMS can't waive. That's going to be an act of Congress. So the question is, in my dealings with providers, I don't think they understand that, and they think once the pandemic is over, this will continue. And you brought up the letter from the coalition. My question is, you know, what pressure do you see is going to be on Congress to do that? And alternatively, and this is more for Kerry, is there a plan to let providers know that this is going to continue to be a hurdle once the pandemic ends?
Yeah, so I'll let Kerry comment on that as well. But you know, one thing that I've been advising all of my clients that have been doing telehealth before, as well as those that have just been dabbling in it over the last couple of months, or maybe recently stood up a very quick telehealth program, is they need to start developing a work plan on when the public health emergency is over, and what do we need to shift. You know, things shifted kind of an emergency ad hoc basis in March and April. And a lot of providers stood up these telehealth programs, and some have been very successful. And now they really need to start thinking about what are we going to do when the public health emergency is over, and I can no longer take advantage of those statutory waivers. Again, a lot of the regulatory flexibilities may be in place, but they need to take a hard look at what on the regulatory side as well as on the statutory side, like that rural originating site, what is going to go back to pre-public health emergency requirements, and how am I going to deal with that? So I think that's a good point, and I think it's where we can come in and really advise our clients on developing those kind of work plans and thinking through those issues.
Yeah, and certainly we have a running list of all of the things, both telehealth and non-telehealth related, that we're going to have to be reminding people that are going to be different as we get to the end of the public health emergency, both on the federal and the state level. You know, I'll say the American Hospital Association, working in coordination with the coalition, has been very busy on this front. And, you know, as Sean discussed, there's movement at CMS, and they are on board with making these changes, even though some of them require congressional action. The feedback that the AHA has been getting from Congress has been generally positive. Now, getting it done is a separate issue. And, you know, frankly, I think that, you know, 3 or 4 months ago, we were hopeful that we might have been able to get it into one of the COVID relief packages this fall. It's looking less like that's going to happen, but it's certainly something that continues to be on our radar, and that we continue to pursue, hopefully before the end of the public health emergency, so that there is, if not a seamless transition, then maybe a rocky transition as opposed to a cliff.
Great. Well, thank you. Thank you, Sean. That was great. Appreciate it.
Thanks for having me.
We are out of time. But thank you for offering to follow up on any questions that we may have, and we will certainly follow these changes and invite you back. All right. Our next session we have is going to be on the past Georgia legislative session. There were several pieces of important legislation that will touch healthcare and will impact our clients. Anna Adams couldn't join us today, but Ethan James has graciously agreed to jump in on short notice. Thank you, Ethan. Appreciate you being here today. Ethan is the Executive Vice President of External Affairs for the Georgia Hospital Association, where he's been for the past 13 years. Prior to joining GHA, Ethan worked for Children's Healthcare of Atlanta, the Georgia Department of Human Resources, the Georgia General Assembly. He is a board member of the Georgia Pain Initiative, and he is a graduate of the Georgia State University. Welcome, Ethan. Thank you very much for jumping in, and we appreciate you jumping in. Thank you.
Amy, thanks so much for having me. Can you all hear me okay?
Yes.
All right. You were going to get a treat listening to Anna Adams talk about this past legislative session, but she is so popular. She got called into a DPH emergency call related to some of our data reporting with the feds. So she apologizes that she can't be here with you today, but I'll do my best to pinch hit for her. I think what I was asked to do is not only go over some of the highlights of the past legislative session, but to really give some insight into some of the politics behind it, which is much better for me since I'm not a policy guy. I do have a PowerPoint, and that is really just up there to give you all something to look at other than having to look at me and strain your eyes. We entered last legislative session preparing to go over some of the usual things, especially certificate of need. The attacks on the CON process seem to be never ending. Of course, we're also going to be working on surprise billing that we had been working on for, I think, 5 or 6 years, and hopefully see an end of that. Always interested in Medicaid reimbursement. That's kind of, I always feel like a realtor. They talk about location, location, location. We go down to the General Assembly, and because the state appropriations are so important to us, I'm thinking Medicaid, 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 and that is one of our primary focuses. Tort reform, of course, with the chamber and the Georgians for Lawsuit reform, all of their efforts that we endorsed and worked on, we were so interested in helping them out and participating in that from a hospital and healthcare provider perspective. But of course, then we had this little coronavirus thing come along and upset the apple cart. And really all of those things kind of took a back seat as the General Assembly took in a shockingly long time. I remember back in 2010 when they were working on passing the provider tax. We called it the hospital bed tax back then, but the provider tax, or some call it the provider fee. The General Assembly shut down for 2 weeks while we negotiated that, because then Governor Sonny Perdue had threatened to either do away with our not-for-profit sales tax exemption, cut our Medicaid reimbursement by 20%, or come up with this hospital tax. And they shut down for about 2 weeks while they negotiated that. And at that time, that seemed like just an extraordinarily long time for the General Assembly to recess for 2 weeks to work on that. But the General Assembly recessed after day 29. Maybe it was day 30 now, suddenly I can't remember. I think it was day 30. There were 10 days left in session, and recessed for months while we tried to get a handle on how to best address COVID-19 and keep participants, legislators, and staff and the general public safe down at the Capitol before they opened it back up. So by the time they did open back up in mid-June, we had pretty much given up on a lot of the legislative priorities that we were able to work on. But it quickly became apparent that tort reform, at least the liability protection for healthcare providers, was certainly going to be one of the most important things that we still had to do, in addition to, of course, the constitutional mandate that the General Assembly pass a balanced budget. We were so appreciative of Governor Kemp and his efforts to afford us some of that liability protection during the downtime of the General Assembly, as he passed some executive orders in order to make sure that we had that flexibility. It was going to be so difficult for especially hospitals to make the necessary decisions as a result of the crisis, including delay of elective procedures, rapid implementation of care, other medical countermeasures and new technologies, without that liability protection. You know, we had so many people that were fearful of pending lawsuits that we would face while we were just trying to do the right thing and figure out how best to care for our patients. Some of the interesting things that came about, I will tell you some behind the scenes, and a lot of things go on behind the scenes at the Capitol. We are so grateful for our advocates and for our hospital members as they explain how policies and laws impact their facilities and their ability to treat patients. And of course, we certainly appreciate the entire healthcare attorney community. Y'all provide so much insight into those policies and laws. Really couldn't do it without you. But this was shockingly behind the scenes. I mean, just the negotiation going on between such a small group of stakeholders Of course, it included the Georgia Chamber, who very rightfully took advantage of this situation. Their tort reform, GLR's tort reform efforts, I think, were pretty much DOA as we ended the first part of session. But they got revived when the hospital community started talking about their need for liability protection. But the Chamber of Commerce, of course, wanted liability protection for their business community as well, dealing with COVID. So if somebody came on premises, that these businesses were not going to be sued as potentially spreading the virus or as a source where individuals might catch that virus. So it was the Chamber of Commerce, the Georgia Hospital Association, of course, the Georgia Trial Lawyers Association, and so many different healthcare and trial lawyers involved in those issues. The Medical Association of Georgia and other specialty physician groups, including the Georgia Dental Association. But they were working with Senator John Kennedy, who's from the Macon area. He is the Majority Caucus Chairman and also an attorney from down there. Senator Bill Cowsert from the Athens area. He is not only a defense attorney, but he's the former Majority Leader, so still wields a lot of influence. Over on the House side, it was the Majority Whip in the House, Trey Kelly, who's from Cedartown, and he is a prosecuting attorney. So we had lots of different perspectives going into exactly how this was going to work. And again, I would say that I think the chances for the GLR big tort reform package had pretty much been DOA in the House, as they were not going to take up anything similar to that. But then came this need for healthcare liability protection. Let me tell you, I've been involved in so many behind the scenes battles and things going late into the evening during session, especially on day 40, sine die, the final day of session, where so much is happening and things are changing second by second. But there's a real skill set between killing a bill, which I think has really become one of my specialties with regard to killing bills that deal with certificate of need erosion, and passing a bill. And to pass a bill of this magnitude that had been fought tooth and nail for so many years in the General Assembly, to be able to pass that in the final 2 weeks, literally 10 days, a Monday to the following Friday, to be able to pass that was nothing short of miraculous. And I wanted to give a lot of credit to all those people working behind the scenes, especially the leadership of the House and the Senate, and Governor Kemp as well for lending his support for this effort. Importantly, SB 359, you can see this is the bill that ultimately passed. It does not provide blanket immunity. And this was important, especially to the trial lawyers. They didn't want to go too far with that pendulum swing. But what they did come up with, especially for the business community, was a posting. This is in the law. This is a posting that businesses can place outside their place of business, warning folks about the inherent risks of entering these facilities. Hospitals can do that. Healthcare facilities can post this. But I think because we already have other standards in this law that protect us, I'd be very surprised to see any of our hospital members posting these types of warnings. What we did get was something that we're very used to, kind of a gross negligence standard. Let me check my notes here real quick. Healthcare providers are still liable for injuries resulting from gross negligence, willful and wanton misconduct, which is something that the business community and the chamber really fought to get into that language. So we thank them for that. Reckless infliction of harm or intentional infliction of harm. But as an earlier slide said, this will protect us as we try to treat these COVID patients with new technologies and treatments. I'll tell you what, Amy, I don't want to wait till the very end because I know time may be limited. I will take any questions at all if someone wants to speak up, if they have a question about anything I'm saying or want additional information. So before I move away from the liability section, so if anybody has any questions.
Sure, if anybody wants to submit any questions through the chat, or I believe you're able to unmute if you have any questions for Ethan.
Thanks, just shout out and get my attention. I'll be happy to pause. The issue that we had been working on that we were still able to turn a great deal of attention to this session was the surprise billing issue. We refer to that as balance billing, not surprise billing, in the healthcare community. But the goal was for the last 6 years is to figure out a way for a patient to be removed from the billing process. They pay their insurance premiums, they pay their deductible, and still maybe 6 to 9 months later after they've received their treatment, it was becoming more and more common for a patient to receive what they were surprised to receive, a bill for services. And that's because the claims adjudication process, of course, takes so long. I even heard some cases of surprise bills showing up more than 2 years after that patient received treatment. And of course, that impacts their credit. From the Georgia Hospital Association's perspective, we believe that the patient should be removed from that process because we don't believe that a patient can heal physically if they are stressed or have financial anxieties. That certainly does play into the healing process. So while we talked about these out-of-network bills and surprise bills that these patients were getting, and again, this process took 6 years of negotiation between the House and Senate and the insurance industry and the healthcare industry. Everybody had a different idea on how to do it. I think the insurers were offering us some sort of percentage of Medicare. I think at some points they even talked about, wow, we'll even give you 500% of Medicare for some of these procedures. I would always argue, and the hospital community would argue, that Medicare is such an unstable base. You know, we see Congress continually trying to cut Medicare rates and save on Medicare, and the provider community gets lower and lower reimbursement for Medicare services. That it really wouldn't have mattered what percentage you put in there. If your base continues to get eroded and rapidly for certain procedures, that percentage is just not going to work for us. The physician community they were pushing the Fair Health model, which is a national model of claims database, and they were looking at trying to come up with a percentile, not a percentage, of the fair claims that were submitted as a standard for reimbursement. But House Bill 888, which did pass, it took a provider getting involved in these negotiations. Representative Lee Hawkins from Gainesville is a dentist. He's a healthcare provider, and he certainly understands the frustrations, and as a patient understands the frustrations of receiving these surprise bills and so much of the trouble with the insurance billing process. And I'm sure there are probably some healthcare attorneys that work for insurance companies that are on the meeting, on the Zoom call. So no offense intended. But House Bill 888 did finally pass. It was a very good compromise, and you see some of the stipulations in here on these slides. I tell you what, I would probably not share these slides, Amy. I know you don't have them, but what I would offer to do is make our legislative summary, which is very in-depth summary. It's a big book that we publish every year about all the bills that impacted the hospital community. I would ask Kerry to perhaps, if it was appropriate, make that available to the health law section and share our legislative summary with them, and therefore you'll get our perspective on all of this legislation, as well as our summary of it. I'll quickly go through some of these other slides. Of course, the very comprehensive surprise billing legislation did include some provisions regarding non-emergency services. If a patient chooses to go to an out-of-network provider as opposed to an emergency service, perhaps they're unconscious or in a car wreck and they get taken to an out-of-network hospital facility, that is a very different situation. So it addressed that. It addressed the all-payer claims database that Kerry, you did such a great job with the fireside chat earlier. I won't go into any of that, but also it includes arbitration, credit reporting, and enforcement provisions. So before I move on to PBMs, which I was told you also are all very interested in, let me pause again to see if there are questions on the surprise billing legislation or any of those politics and behind the scenes negotiation. right, PBMs. I'll tell you what, again, I've been on the hot seat many, many times in my career, sitting before a legislative committee and getting grilled with less than friendly questions. I have not experienced the kind of awkwardness or third-party embarrassment, I guess you could say, sitting in the peanut gallery in the audience for some of these committee hearings as I did when the PBMs were on trial before Representative David Knight, who's from south of Atlanta in Spalding County. He is a dog with a bone when he gets interested in an issue. And he got interested in some of the concerns about pharmacy benefit managers and the monies that they're making and purporting to save consumers and businesses so much in healthcare costs. But both he and Senator Dean Burke introduced legislation to to restrict pharmacy benefit manager practice. Senator Dean Burke is from Southwest Georgia. He is a physician. He is a hospital employee. And he is also very influential as the chairman of the Senate Appropriations Health Subcommittee. They did joint legislation, and both of them passed, and they will become effective January 1st. And let me tell you what, the PBMs, again, they got grilled up there, and really were brought to heel on a lot of their practices. Including national average drug acquisition costs. I'm blanking on some of the terms, the prohibitions on patient steering, and withholding coverage for prior authorizations, just so many of the practices that they engage in that have been brought to light and shown of the abuse for these folks. But again, the behind the scenes negotiations, and I would really give a lot of credit to the Georgia Dental Association. I'm sorry, the Georgia Pharmacy Association, who had really worked for many years with Representative Knight on this legislation, and did a great job before committee, and also working the floor to pass this bill. I've really never seen such a tremendous effort against such a large industry. That has been operating, some would say unscrupulously, in Georgia for many years. Amy, that's the gist of it. I know I did only have a short time during lunch here, and I wanted to save plenty of time for questions just in case I didn't cover any of the hot button issues that y'all were looking for. So with that, let me just go ahead and open it up. I included especially Anna's contact information on here. She has great insight. She worked each one of these issues so thoroughly during session. So if you do have any specific questions, contact either one of us. But with that, I'll certainly open it up to the floor for any questions, or if you'd like to bring up other topics.
We do have one question. Are the new anti-steering provisions intended to apply only to new arrangements entered into after 1/1/21? In other words, are existing arrangements that involve patient steering grandfathered in?
That might be a question I get Kerry Connolly to weigh in on. Kerry, what is the legal answer to that? Because my recollection is that it was moving forward new contracts.
I don't know the answer to that, Ethan. I would have to go back and look at it. It's not something that I have paid particular attention to, since it doesn't directly impact hospitals.
All right, we can get you that answer. We'll follow back up with Amy.
And we have one more question. Was there any discussion at the legislature about a violation of the new anti-steering provisions becoming a predicate for a violation of Georgia's Deceptive Trade Practices Act?
I don't know if that was specifically a part of either a floor testimony or a committee hearing, but I can tell you that I was part of, Anna had included me in some of the conversations with Representative Knight, Senator Burke, and the Pharmacy Association, and that was certainly brought up and discussed as a perhaps a path towards stopping these practices. But I don't know that got included in the final version of the legislation. Again, I'll have to look that up.
The other interesting tidbit related to the various pieces of PBM legislation that came up periodically this year and over the last couple of years as they've been discussed is the ongoing legislation that's currently at the U.S. Supreme Court related to I think it's a state law out of West Virginia related to PBMs and whether or not it's a violation of ERISA to regulate them at the state level. And certainly whatever the decision is from the Supreme Court on that will impact Georgia's new regulations on them. So we'll have to be keeping an eye on that.
Amy, thank you so much. Really appreciate y'all including us and letting me join you here today. Again, always appreciate everybody's input and perspective as we tackle so many of these challenges down at the Gold Dome.
Ethan, well, thank you. I know you had short notice and appreciate you jumping in today and providing this information. I guess a quick question that you may or may not be able to answer, but for the next session, is there anything that is in the hopper that we should be looking out for?
Well, I tell you, I mentioned at the beginning the location, Medicaid. The state is still in a budget crisis. Remember, Governor Kemp originally suggested that state agencies cut their budget back in June by 14%. Ultimately, they only had to do that by 11%. While Governor Kemp has not directed the OPB, Office of Planning and Budget, to make any additional cuts yet, I will tell you that some of my conversations with state leadership indicates that they are still facing a significant hole in this upcoming budget. So I think a lot of things are, again, going to be considered for cuts, which impact all of us. And it certainly impacts the provision of care for our patients when they start cutting healthcare programs. Again, luckily we were spared any of those significant cuts in last year's budget, but as they start cutting the fat and the meat away, eventually they do get to the bone. So we are of course always concerned about the state budget and the cuts that they may be forced to do. As always, certificate of need will be on the table. I know that there are efforts underway already to do things from minor tweaks, maybe regarding freestanding emergency rooms, all the way up to there are certain pockets of the General Assembly that want to completely undo the entire certificate of need process and do away with it, at least for hospitals and physicians, not necessarily for nursing homes. One thing that we are preparing to do is address in statute exactly what a emergency or pandemic response would look like. So many of this was done, so many of this response was done through executive order. And we discovered that Georgia is one of the very few states that has not codified their pandemic response emergency orders. So we'll be working with state leadership on figuring out exactly what that means. Hopefully we can get something in code and be better prepared for the next pandemic that comes along.
I would add to that for all of you younger lawyers there that may feel like sometimes you get sent off to do volunteer projects or pro bono work that may seem like it doesn't mean anything. Back when Keith Moriello and I were baby lawyers, we did a pro bono project working with the Georgia Hospital Association on emergency preparedness. I don't know, Keith, it was more than 10 years ago. Keith Moriello, who's a former chair of the health law section, and that information I dug out from the Georgia Hospital Association files and was very valuable to me when all of this pandemic craziness started, and having to get some of these requests to the governor's office for various help in the executive orders and the language that we needed for the waivers and protections, because we had worked on that all of those years ago. And I have a feeling that some of those things are now going to be the basis for what Ethan's talking about moving forward and some of the things that we need to get codified. So what you're doing is meaningful, whether you think it's meaningful now or not.
Well, we are officially out of time. Again, thank you, Ethan, for joining us today. We really appreciate it. The summary that you mentioned, Kerry has let me know that that is in the final stages of being finalized. And once that is finalized, we will send that around. But today you will get the other slides and information that was presented today. Thank you for joining us today. Please don't forget to sign up for next Wednesday, same time, 12 to 2, where we will discuss transactions, and the Wednesday after, where we will have our annual fraud and abuse panel. Hi, Tony Cochran.
Hello, Amy. Thank you.
Thank you, everyone. Appreciate it. And if you have any issues with getting the materials or any issues with registration, please reach out to me or Lane. And have a good rest of your week.